Assalamu alaikum. I thank Professor Salah Naga and Professor Iman al-Gohri for giving me this marvelous opportunity to address this distinguished audience. My talk is very short, and it's about C3 glomerulopathy with highlighting the role of complement. Now, membranoproliferative GN is not a diagnosis. It's a pattern of injury, and we have to seek the underlying cause. So what is the typical MPGN pathology? You have accentuation of glomerular tufts, mesangial hypocellularity, endocapillary proliferation, GBM duplication, with typically peripheral capillary wall deposition of immunoglobulins, complements, or both. Now, primary MPGN is divided into three subtypes based on the ultrastructural appearance and the location of the electron-dense deposits. This is a table just to highlight the findings in each type. So MPGN type 1, you have mesangial proliferation, interposition, and GBM duplication. The same pattern, you have it in MPGN type 3. However, you have a more membranous inclined features. So if you have both GBM thickening, diffuse GBM thickening, and diffuse hypercellularity, it is an MPGM pattern, but you better look for the subtype on EM. By electron microscopy, MPGN type 2 is dense deposit disease, and you may have an MPGM pattern, or you may have a diverse of other patterns of injury, which we're going to address later on. Now, by EM, you have, in type 1, you have mesangial and subendothelial deposits. In type 3, you have mesangial, subendothelial, subepithelial, and or intramembranous deposits, which are responsible for the more membranous inclined type of morphology. And in type 2, which is the dense deposit disease, you have the characteristic intramembranous, highly dense, electron-dense, cigar-shaped deposits. So C3GN is a group of glomerular disorders in which there is dysregulation of the complement system, and it may be the key pathological factor responsible for this type of pattern of injury, or the major mediator of glomerular damage. Recent classification, not so recent, it's divided into immune-mediated and non-immune complex-mediated. Now, this classification is even starting to change as we speak, because there are new insights into the role of complement in the pathogenesis of even immunoglobulin-mediated disease. So if you have an MPGN type morphology and you have both immunoglobulins and C3 on immunohistochemistry or immunofluorescence, then this is an immune complex, straightforward immune complex mediated GN. If you have a C3 alone on immunofluorescence or immunohistochemistry, then this is a C3 glomerulopathy with activation of the alternate complement pathway. If it is mainly a cigar-shaped, dense intramembranous deposit on EM, this is dense deposit disease. If it's mesangial, mainly with other locations of deposits, then this is a C3GN. So you really need ultrastructural study to arrive to a definitive diagnosis of dense deposit disease or C3GN, in addition to the immunofluorescence. Again, this is almost a duplication of the previous slide, a little more detailed, just to highlight that MPGN type 1 pattern of injury may have both activation of the classic alternate complex, classic pathway to yield an MPGN type 1, or you have a C3 deposits alone, and this is considered a form of C3GN. On the other hand, MPGN type 3 is the same, and then in the middle you have the cigar-shaped electron-dense membranous deposits. Now, I copied this off of a reference as it is, but I want, as you can see, I highlighted the word alone in the C3 deposits. Now, with advancing understanding of the role of complement, alone is really not that strict. Alone means there's nothing else but C3, meaning that the immunoglobulins have to be negative. This is not the case because with advancing understanding of our understanding of the role of C3, we know that we can have immunoglobulins in the glomerulus, but the upper hand or the greater density of the deposits is actually C3. So you can label immunoglobulin a C3 glomerulonephritis in the presence of immune deposits, but there has to be a twofold difference in the density of the deposits, meaning that the immunoglobulins have to be a 1+, and the C3 has to be a 3+. So there has to be a twofold difference of magnitude in the deposits of C3 and the immunoglobulins to label an immunoglobulin-mediated GN with an underlying C3 abnormality. So complement is activated through 3 pathways, and the central pathway involves activation of C3 convertase to cleave C3 into the anaphylatoxins C3A and C3B. C3B activates C5 convertase to activate synthesis of the final pathway with generation of the membrane attack complex C5-9. Now, the alternate complement pathway is constitutively active at a lower level, and this is called a tickover. And this is a physiologic basal activation of the alternate complement pathway with spontaneous hydrolysis of C3 and production of C3b, and C3b binds complement factor B to yield a fluid phase C3b convertase. Now, this pathway is tightly controlled by specific inhibitors or regulatory proteins, and these are the products of complement factor H, complement factor I, MCP or CD46, and the 5 factor H related proteins. So these are the key inhibitory or regulatory factors of this pathway. Now, the principal activating proteins of C3 convertase are C3 and CF, complement factor B. And this is just a representation of what we said. So in cases of autoimmune abnormalities, we have acquired autoantibodies directed against activating or regulating protein, and we have unregulated activity of C3 and C5 convertase. Let's talk about the C3 nephritic factor. The C3 nephritic factor is an autoantibody against C3 convertase. So it directly stabilizes this C3 activating complex of the alternate complement pathway and prevents the inhibitory action of complement factor H and prolongs the half-life of C3 convertase from a few seconds to up to 60 minutes and increases the generation of C3 and C5 convertase. And this is a study about the prevalence of the nephritic factor in the two forms of C3 glomerulonephritis, and as you can see, it's much more prevalent in the dense deposit disease. So we don't know the exact degree to which the C3 nephritic factors contribute to the C3 GNs, and they can be detected also in healthy individuals as well as in other glomerular and non-glomerular diseases. And many of these C3 nephritic factor patients will have a second or third abnormality detected on screening. And they have accompanying genetic abnormalities in coding complement factor H. So the pathologic forms, you have dense deposit disease. And with the dense deposit disease, you have autoantibodies against complement factor H, so the C3 nephritic factor, and a genetic deficiency in complement factor H. Now, here's the, I think we have to take care that dense deposit disease doesn't have to be an MPGN type morphology. You can have a mesangial proliferative pattern, a concentric pattern, an exudative pattern of GN like what you see in post-streptococcal, and a typical membranoproliferative pattern, but it is not restricted by all means to membranoproliferative changes. And this is what we see on transmission microscopy, this cigar-shaped, extremely electron-dense deposit in the GBM. And this is actually one of our cases where we do immunohistochemistry. We don't do immunofluorescence, so you can see this is a C3, and this is what we mean by a 3+ positivity. And by TM, we found this extremely dense intramembranous cigar-shaped deposits. Interestingly enough, this case was an infective. It has a morphology of an exudative pattern of GN. But there was a marked difference in the intensity of staining and in the number of mesangial deposits we found on EM. So it was defined, or it was diagnosed as post-infective, but with an underlying C3 abnormality. So the second form of C3GN is C3GN glomerulonephritis. It is characterized by isolated glomerular C3 deposits, and you have mainly mesangial electron-dense deposits. Again, it doesn't have to have a MPGN type morphology. Now, there's a specific report of 2 Cypriot families with inherited renal diseases with subendothelial deposits of C3 but not immunoglobulin, and they had mutation in complement factor H-related protein 5. Again, just to demonstrate the heterogeneity of the presentation of a C3GN, I'm just going to go very rapidly through apparently immunoglobulin-mediated diseases which have an underlying C3 pathophysiology. So atypical HUS, it's now a well-known cause that it is mediated through inactivating mutations in genes encoding complement factors H, I, MCP, and thrombomodulin, and gain-of-function mutations in genes encoding C3 and CFB, which are the activators of C3 convertase. Atypical post-infectious GN is also another disease which apparently is an immunoglobulin-mediated disease, but it has an underlying pathophysiology of C3 abnormality. IgA nephropathy is another disease in which complement has a very important factor in its pathogenesis. So there are multiple associations between the alternative lectin and terminal pathways and IgA nephropathy severity. There are ongoing therapeutic trials for inhibition of the complement pathway for treatment of this disease. Now, lupus nephritis is a big story. There are multiple evidences pointing to the pivotal roles for the complement system in the pathogenesis of SLE. And may potentially provide non-invasive markers for disease activity and even targets for future therapy. So the low total complement hemolytic activity and decreased C3 and C4 levels have been found in about 75% of SLE patients with focal nephritis and 90% with diffuse nephritis. SLE patients carry mutations in CFH and MCP, have an earlier onset of lupus nephritis, and lower leukocyte MCP expression is associated with lupus remissions. Successful treatment of C1q deficient SLE patients with fresh frozen plasma or hematopoietic stem cell transplantation has been reported. Anti-C1q antibodies are associated with proliferative lupus nephritis, and its levels indicate renal disease activity. And in the presence of sera from individuals deficient in C1q, C4, C2, or C3, phagocytosis of apoptotic cells was decreased. which is the forerunner for development of intolerance and clinical manifestation of lupus disease. It also plays an important role in thrombotic complications of SLE. The take-home message here is, even if you have an immunoglobulin-mediated GN based on biopsy with everything done for it properly, and you have immunoglobulins, but you have to critically appraise the intensity of staining and the TEM findings in order to unravel the possible underlying C3 pathogenesis. Thank you.